Welcome, everyone. My name is Morgan Harrington, and I'm the National Coordinator of Programs here at the American Liver Foundation. I'd like to be the first to thank you today for joining us for our Obesity and MASLD, Understanding Your Risk webinar. ALF's mission is to promote education, advocacy, support services, and the research for the prevention, treatment, and cure of liver disease. As part of our commitment to the liver community, ALF offers a range of educational programming and resources for both patients and providers. You can find more information at liverfoundation.org. Our newest resource here is the American Liver Foundation Patient Registry, the first ever patient registry for all types of liver diseases. Our goal is to help researchers better understand liver diseases and how these diseases and current treatment options impact patient lives. The registry is open to individuals 18 and older who currently reside within the United States with any type of liver disease at any stage, including liver transplant recipients. Participation is easy and includes a user-friendly online survey that will take about 15 to 30 minutes of your time. You can use the QR code here on the screen or the link to learn more or participate in the registry. Don't wait. Share your experience to help change the future of liver disease. Our speaker today is Dr. Gary Abrams, a professor of medicine at the University of South Carolina School of Medicine in Greenville, South Carolina. He earned his medical degree from Albert Einstein College of Medicine and completed his residency and GI liver fellowship at Yale. With 30 years of academic experience, Dr. Abrams has focused in general hepatology, researching pulmonary complications of cirrhosis, and metabolic dysfunction of steatotic liver disease. He has authored over 60 peer-reviewed publications and led numerous clinical trials. Former chief of the GI liver division at Prisma Health, Dr. Abrams also established the GI Hepatology Fellowship Program and continues to contribute to research and education. Additionally, he currently interprets FibroScan studies for assessing fatty liver and fibrosis at Prisma Health. If you're looking for more information after our webinar today, we encourage you to visit liverfoundation.org. There you can also find details about our virtual and online support groups, as well as get involved as an advocate. We'd also like to invite you to connect with us on social media. You can find us on Facebook, Instagram, LinkedIn, X, formerly known as Twitter, and YouTube. We look forward to staying in touch. With that, I'm now going to turn our discussion over to Dr. Abrams to get us started.
Good morning, everyone. We're going to talk about two topics that are extremely common, both obesity and MASLD, which will be defined. Obesity, excess body fat that poses health risks, such like heart disease, stroke. Fat tissue is not measured when you go to the clinic. Going forward, it is important to know, do you have fat tissue or not? And probably what will become commonplace is that your waist will be measured. And if you're 35 inches or more in a female or 40 inches in a male, that will be considered excess fat tissue. And obesity is truly defined by excess fat tissue and not what we usually have done in the clinic, which is your BMI. So your BMI is a formula for both height and weight. And as you know, your BMI might be very high, but if you're a linebacker for the NFL football teams, you'll have next to no fat on your body and yet have a very high BMI. So BMI alone is commonly used in the clinic, but is not a good indication for excess body fat, which defines obesity. Overweight BMIs between 25 and 29.9, and 85 million individuals in the USA are overweight. The classes of obesity are 1, 2, and 3, BMI 30 to 35, 58 million USA, 35 to 39, 26 million, And if your BMI is 40 or more, 19 million. So this is around 60 to 70% of adults in the USA are either overweight or obese per the BMI calculation. But moving forward, waist circumference and BMI should be identified to determine whether you have excess body fat. Adipose tissue. That's what you can grab if you have excess body fat around your abdomen, where your waist measurements will be. There are two types of excess fat: the superficial fat that you can grab, and the visceral fat, which is deep inside your abdomen, which you cannot grab. Adipose tissue is made up of fat cells called adipocytes. The adipocyte has a fat droplet, a nucleus, and a cytoplasm, which all cells have in the body. The adipocyte is specific because of this large fat droplet, which really looks like an empty space when you're looking under a microscope. And in this fat droplet are fats that provide energy for the cells throughout the body. So what are your risk factors for obesity? Well, the first one is eating excess calories. Even if it's healthy calories, if you eat more than you burn off in a day, your calories will accumulate and you will build excess fat tissue. Ultra-processed foods and junk foods and sweets are high in calories, fat, and salt, and these should be avoided or eat very rarely. Inactivity. Your body will normally burn fat at rest. If you're inactive and don't exercise, it's very easy to eat more calories than your body's able to burn at rest. So your calories will accumulate and your fat tissue will increase. So inactivity is a very common cause for obesity. In addition, family history, stress, and poor sleep add to added fat tissue. So what we call obesity-related disorders is when the excess fat tissue actually causes illnesses, and they could be considered as diseases or disorders. So this is the fat tissue causing type 2 diabetes, very common. Fat tissue causing heart disease, hypertension, heart failure. It can cause stroke. It can cause many types of cancer and a condition called fatty liver disease, now called MASLD. Obesity therapies. They include diet and regular exercise. The Mediterranean diet is a very common diet that is often suggested because it has low fat, saturated fat for sure. It has a lot of vegetables and staying away from meats that have a lot of saturated fats. But any diet, portion controlled, where you're not eating excess calories, will prevent or treat obesity. Regular physical activity includes at least 30 minutes of walking at a moderate pace, preferably 3, if not 5 times a week. Behavioral support, cognitive behavioral therapy, and others can be very helpful in helping to determine what potential triggers or situations you are in that may add to eating more food than you should be. Pharmacotherapy, medications. The GLP-1 agonists are very commonly seen now on commercials. They include Ozempic, Wegovy, Mounjaro, and we'll talk more specifically about these at a different web. Endoscopic procedures. The gastroenterologist or surgeon can now put a scope into your stomach and actually suture your stomach to a smaller size. That will make you feel satiety. You'll feel a lack of hunger while you eat. You'll get filled up much sooner, so you'll eat less. And this is through your mouth, so there's no cutting or surgery on your abdomen. And then the final is bariatric surgery, where you do have surgery that actually makes your stomach very small, so you get full very quickly when you eat. The last two procedures are only for those who have excessive fat tissue in addition to comorbidities. So the next topic is metabolic dysfunction associated steatotic liver disease, or MASLD for short. This is a very common problem that is associated with obesity. So what happens is you have excess fat tissue, and that sends fat deposits to your liver. Inside the liver, your liver normally takes this fat and makes it into energy, and may send it out to the rest of the body for energy. However, if you're sending too much fat to the liver cannot make all energy that's being sent to it. So the fat builds up inside your liver cells. And we'll see a picture of that in a minute. The risk factors for MASLD include the conditions that are often associated with obesity. Type 2 diabetes is the big one. Hypertension, dyslipidemia, meaning high triglycerides, high cholesterol, a condition called polycystic ovarian syndrome, which is associated with insulin resistance, and genes. There are several genes that do put people at risk for fatty liver disease. If you have the genes, it doesn't mean you will definitely get fatty liver disease, but you are more prone to it. MASLD can lead to liver cell injury. That's called MASH, metabolic associated steato. Steato is fat. Hepatitis is inflammation of the liver, and inflammation of the liver is when the liver cell is injured. It can also then lead to scar tissue, which is called fibrosis. The fibrosis is if you cut your arm, as the skin heals, you'll see a scar. Well, where the liver cell injury heals, it is replaced with scar. So histologically, looking under the microscope, there's a continuum of MASLD. This picture is a normal liver. You see a lot of pink and blue nuclei. That's what it normally looks like when you're under the microscope. The next two slides, the first one is adipocytes that you saw earlier during the obesity talk, and the third is fatty liver. When you're looking at this slide, you see these fat droplets that are identical to the fat droplets in adipocytes. The fat droplets in the liver are not adipocytes. This isn't a cell in the liver. This is just the accumulation of fat because the liver could not utilize all the fat and make energy. This last slide is MASH, where the F is in the liver cell is a fat droplet. It's essentially taking up the whole liver cell. You don't even see any part of the cell. And it might look like an adipocyte, but it is not. It's just a fat droplet. The B is a balloon cell. And a balloon cell is a liver cell that's about to die. That's the liver injury. That balloon cell is what signifies MASH. And when you have the steatohepatitis of MASH, that then can lead to fibrosis of the liver. The first picture on the left is a normal liver on a biopsy. The second picture shows a little bit of blue in the portal tracts. That's considered stage 2 fibrosis. The third picture shows a lot of blue, and they're bridging from portal tract to portal tract, and that's called stage 3 fibrosis. And the final picture is cirrhosis of the liver, where you see circular blue around hepatocytes. A lot of scar tissue here and nodules that you'll see in another picture. So there are 4 stages of fibrosis, and these occur or may occur after you've developed MASH. The global prevalence of MASLD. This is a worldwide problem. On average, around 30 to 35% of the world has MASLD. The one continent that does not, or at least the country most that doesn't, is Africa. A study in Dallas looked at fatty liver on a very research-oriented called MRS scan. And what they found was the Hispanic population had the greatest amount of fatty liver, irrespective of gender. In whites, is significantly less, around 30% compared to almost 45% in Hispanics, and men have more fatty liver than women. And then in the African American population, it's the lowest that have fatty liver, and again, the genders are the same. What has been learned since this study is that in Hispanics, they have a greater gene, a greater risk of a gene that causes or puts them at greater risk for fatty liver. So how do you present to the doctor with this condition called MASLD? Unfortunately, it's asymptomatic. Most of the times that this fatty liver is identified is completely by chance. Although people will complain of fatigue, it probably is unlikely related to having fatty liver. It's an incidental finding. You may have abnormal liver enzymes from medication, and then you get an ultrasound of your liver, and they say you have an increase in fat in your liver, or you might have an enlarged liver and identified as fatty liver, but it may not be due to fatty liver. Common scenarios is a person takes a statin for the elevated cholesterol. And statins often cause minor increases in liver enzymes, and then they get an abdominal ultrasound that shows the fatty liver, or it's a medical insurance or occupational health checks. So overall, this is an asymptomatic condition until the very end of having cirrhosis of the liver. Also, unfortunately, is liver enzymes are normal in 80% of individuals with MASLD. So you can have fatty liver and have normal enzymes, and your doctor will not be aware of it. To help physicians determine if you have advanced fibrosis, they can do what's called a FIB-4 test, which is very simple. It's using routine blood tests that they get, and they have a calculator will tell them if it's elevated or not. And the FIB-4 test will help them determine if you might have stage 3 or stage 4 fibrosis. There's something called vibration-controlled transient elastography, and you'll learn more about this in a minute. And that's also called a FibroScan. And that test can actually show all the stages of fibrosis, F1 through F4. The risk factors for having MASH and fibrosis, which is what we're most concerned about, is the metabolic syndrome or any of its components, and type 2 diabetes. And the metabolic syndrome components are hypertension, dyslipidemia, obesity, and insulin resistance. I'm now going to present a scan for a minute, and this is called the FibroScan, which helps identify if you're at risk for fibrosis of the liver.
FibroScan examination. The FibroScan operator will have you lie on your back and ask you to raise your right arm behind your head. With your shirt pulled up to expose your ribcage, allow the operator to correctly locate the FibroScan probe. The painless, non-invasive procedure will begin. With the probe pressed against your side, FibroScan is able to measure a 3 cubic centimeter volume of liver tissue. This large examination volume is 100 times the size of a typical liver biopsy and minimizes sampling error. This unique method of assessing liver stiffness uses vibration-controlled transient elastography, or VCTE. VCTE works by producing a mechanical shear wave from the tip of the FibroScan probe. During the examination, you will feel a slight flick or tap on the skin. This is producing the shear.
Okay, so this is what we see when we order a FibroScan, and this is the ultrasound of your liver, and this wave is measuring the stiffness of your liver. You see in blue here, CAP, it's a score. This person's CAP is 237. If it's greater than 250, you may have fatty liver. If it's greater than 270, 275, you definitely have fatty liver. The orange is your liver stiffness score. If it's under 7, you have no fibrosis or very minimal. If it's over 10, you have potentially significant fibrosis. And if it's over 20, you may have cirrhosis. So these scores, this scan can help identify fatty liver and can potentially identify liver stiffness and fibrosis of the liver. Fatty liver by itself is not entirely benign. There is mortality associated with isolated steatosis as well as MASH. So you don't absolutely need to have fibrosis to have an increase in liver-related illnesses. And this figure shows it. If you don't have fatty liver, there's the blue for all causes of mortality and the green for cardiovascular causes of mortality. Once you develop fatty liver, you see a significant increase in the green. The most common cause of mortality is cardiovascular. It is not liver related, even though there's fat cells in the liver. You don't get liver related diseases until you have MASH and fibrosis. But now you see the blue increase. So it's important to know that there really isn't anything called simple steatosis. Steatosis or fatty liver does put you at increased risk for morbidity and mortality. And it's important that you are aware of that and don't consider it benign just because you don't have elevated liver test or fibrosis. So what's the complications of MASLD? The first figure is a normal liver, and you see it's nice and smooth. In a cirrhotic liver, there's a bunch of nodules, and that's due to the fibrosis encircling the hepatocytes that we saw earlier. Cirrhosis can end up with significant complications. This picture shows ascites, and the ascites is this abdominal that is distended with fluid. If we put a needle in that, we could drain it, and you could drain 20 pounds of fluid that builds up in the liver once you have cirrhosis. Cirrhosis also causes loss of muscle mass, as you can see in the thin arms. This fluid can become infected and cause a peritonitis. That needs antibiotics, and that increases risk for mortality. An additional problem is bleeding from esophageal varices. When you have a lot of scar tissue in the liver, the blood that goes to the liver backs up. And when it backs up, it goes into the veins that goes in towards your esophagus. So this is an esophagus. A doctor's doing an endoscopy. These are swollen veins that should not be there. And this is when the pressure is so great within the vein that it causes bleeding. And you would present with vomiting blood. We can treat this by putting essentially a rubber band around it and stop the bleeding. But once you have either ascites or esophageal varicose bleeding, you're in a decompensated state of cirrhosis and often will need a liver transplant to treat you. MASH also can cause liver cancer, as seen on the figures here. This is a CAT scan, and the arterial phase will enhance the tumor, and then during the venous phase, you don't see the tumor anymore. So liver cancer can also develop in someone with cirrhosis. And of course, if any of these things do happen, a liver transplant may be necessary. So we want to prevent cirrhosis from happening. So what are the therapeutic approaches for MASLD and MASH? Well, going to a weight loss clinic and getting a liposuction is not going to help. So as what we've seen treating obesity, weight loss does also treat MASLD. A small improvement, 3 to 5% of weight loss, can improve the amount of fat in your liver. So you don't need a massive amount of weight loss to start to get rid of the fat. If you lose 10% of your weight, you can help get rid of both the inflammation and even the scar tissue, the fibrosis. We talked about the Mediterranean diet and the medications, GLPs, the Ozempic, the Mounjaro, that we would use in individuals who are obese. We would also consider this as a therapy for MASH. And we'll talk about that more at another time. Exercise alone. Exercising alone reduces fatty liver. We can measure it. That's not with losing weight, that's just the exercise alone. It also can reduce your hemoglobin A1C, which is elevated in the pre-diabetic state, as well as when you have type 2 diabetes. And it decreases the visceral fat that's deep in your abdomen that we can't touch. So exercise is a very important component to a therapy for MASLD. This is the endoscopic surgery and bariatric surgery. The first figure is where actually they cut the stomach away. You have a little pouch of stomach, and then they hook it up to the rest of your small bowel. The second figure shows what we call a sleeve, and that can be done by both an endoscopist through the mouth or the surgeon. And this surgery is considered in individuals who would otherwise meet criteria for bariatric surgery, but also have MASLD or MASH. And finally, a new medication, which is a liver-directed medication called Resdiffra or resmetirom. This medication works in the liver. It was approved in March of 2024, just last year, and it's approved for individuals who have the liver cell injury with stage 2 or stage 3 fibrosis. It improves both the liver cell injury and decreases fibrosis by 1 stage. This medication is now more commonly being ordered and covered by many third-party payers. We'll talk more about this therapy as well as the medications for GLP on a different webinar. So in conclusion, obesity is defined by excess body fat, not by your BMI alone. MASLD is excess fatty deposits within the liver cell that can lead or may lead to liver cell injury, scar tissue fibrosis, cirrhosis, and liver failure. MASLD and liver fibrosis are both reversible via healthy lifestyle interventions with or without pharmacologic or surgical interventions. We can treat this disease, and we'll talk more about this in the future. Have a good day.